Hello, my name is Professor Adrian Banning. I work in Oxford. And it's my pleasure to give the final presentation of the European Bifurcation Club meeting 2021. Today, I'm going to talk about side branch lesion length and outcome from the Ebc Main Trial. Hopefully, this audience are familiar with this trial. It was published in the European Heart Journal last week, but presented for the first time at EuroPCR by David Hildick-Smith in May. So this was a trial of 467 patients presenting with left main disease, which affected both the LED and the circumflex. In the trial overall, there was a 7 millimeter mean lesion length and 2.7 millimeter mean reference diameter in the circumflex when assessed by QCA. As you know, the trial essentially compared a stepwise provisional strategy against a systematic two-stent strategy. Importantly, in the provisional strategy, 1 patient in 5 required a second stent. When we look at what the two-stent strategy was, Clot was used in 53%, TAP in 33%, and DK-Crush in only 5%. 93% had a final kissing balloon inflation. And the outcome was a composite of death, MI, or TLR, with a 12-month outcome. And these are the main results. And as you know, it shows comparable outcomes for the two strategies, either stepwise provisional or systematic dual. So the question we asked ourselves was, how much did side branch disease, how much side branch disease was there, and how did that influence the outcomes of the trial? You'll all be also aware of the definition criteria. And importantly, in this paper by Xiaolang Chen, we saw that complex disease, as defined by the definition criteria, complex bifurcations had a worse outcome, as you see in the panel on the right-hand side there. The simple group in purple did less well than the complex group in green. Importantly, to have a complex bifurcation by definition criteria, as long as it's left main, either side branch stenosis of more than 70% and a lesion length of more than 10, then it's complex. In the analysis we're showing, the lesion length of the side branch comes from the carina to the end of the disease, as shown in the cartoon on the left-hand side there. It does not include any disease proximal to the carina. So this is a post-hoc analysis from the Ebc Main Trial. The side branch QCA has been performed by an independent core lab. And we've classified the side branch disease according to 4 different approaches. A cutoff of 10 millimeters, what the median value of the observed population was, what the tertiles are, low, medium, and high, and how the bifurcation complexity could be judged according to that definition criteria. As you know, within the trial, all events were adjudicated by the Clinical Events Committee, and that primary endpoint, as I've already pointed out, death, MI, and TLR. The analyses that we've done, or Federico's done, we've done on an intention to treat basis using the RStudio software. So this slide is quite important because it shows the distribution of the disease within the recruited cohort. And you see that actually most of the disease was relatively focal. The vast majority, less than 10 millimeters in length. We can see the 2 different approaches here. Provisional is in pink and blue is the systematic, but you see that they were pretty much matched. And importantly, the side branch disease in diameter distribution is also shown there, with relatively small amounts at the higher levels of stenosis, vast majority less than 75%. So this is a very different population to the population treated within the definition 2 trial. So this is the first analysis looking at side branch lesion length. In the top panel, less than 10 millimeters. In the bottom panel, greater than 10 millimeters. So importantly, in the bottom panel, those longer lesions, we see relatively small numbers of patients at risk in the Kaplan-Meier curve, but we see a trend towards favoring systematic dual approach, but it is just a trend. This is where we've taken the median and we've done the same analysis. At the top, we've got the shorter lesions where you see that the 2 curves pretty much lie on top of each other. And at the bottom, we've got greater than 5.177, the median. Really no difference in those appearances. And here we've done a tertile analysis of the lesion length. In those very short lesions, in the left-hand panel, you could perhaps argue that there is a trend towards favoring the provisional stepwise approach. And here are those tertiles again, first tertile, second tertile, third tertile, looking at the outcomes. Once again, the more complex two-stent approach really showing no benefit in these analyses. And when we look at the definition criteria, in the bottom panel, those that are positive to the definition criteria, the first thing to point out is that the numbers there are very, very small. But there is a trend for preferential outcome for the systematic two-stent approach, whether we look at the primary endpoint in the left panel, TLR in the middle panel, or myocardial infarction in the right panel, which actually myocardial infarction comes out as statistically significant, despite the very small number of patients. So that's an interesting finding, that in the EBC Main trial, those patients who fulfilled the definition criteria, there is a trend towards an improved outcome with a two-stent approach. So in conclusion, only a few patients, including the EBC Main trial, meet the criteria for a complex bifurcation lesion if you use the definition criteria, 4.25%. There were no significant differences observed between provisional stenting and systematic dual stenting across the different cutoffs of side branch lesion length, but a trend was noted in favor of provisional stenting in the presence of discrete short side branch lesion length, those within the first tertile. And provocatively, in the presence of a complex lesion bifurcation according to definition criteria, systematic dual stent strategy appeared to show a significant reduction in MI at 12 months. But this result should be interpreted cautiously because of the very small sample size. I look forward to discussing these results with you. Cheers.